Hello, everyone, and welcome to the law enforcement role in tackling the opioid epidemic. My name is Emily Murphy, and I am the East Bay by the Alameda Contra Costa Medical Association. Contra Costa.
Emily, you are actually freezing.
Coalition, the East Bay Safe Prescribing Coalition, the HIV education. Are you able to hear me now?
Yeah, you just keep going in and out.
Okay, let me know if it doesn't get any better, okay? This program is also brought on by the HIV Education and Prevention Project of Alameda County, the In Your Corner Task Force, the Alameda County Young Adult Opioid Initiative at the Alameda County Probation Department, Napa County Medical Association, National Coalition Against Prescription Drug Abuse, Northern California High Intensity Drug Trafficking Area, the Solano County Medical Society. And once again, thanks for tuning in today. And with me today, I have David Lopez, the East Bay Safe Prescribing Coalition Project Manager, and Alejandra Hinojosa, also the East Bay Safe Prescribing Coalition Project Team Lead. Next slide, please, David. The purpose of this is to increase awareness among law enforcement personnel on what substance use disorders and opioid use disorders pertaining to substance use and mental health service enforcement agencies. And David, are you still able to hear me? Okay, for our next slide, the Alameda Contra Costa Medical Association, also known as the ACCMA, is a professional association of physicians who are committed to addressing health issues of concern to patients and doctors within the East Bay. The East Bay Safe Prescribing Coalition is a community project that is housed under the ACCMA. And with it, the East Bay Safe Prescribing Coalition began as an effort to reduce
Emily, you're cutting off. I'm gonna actually change.
By engaging appropriate pain management practices.
Emily, you keep getting cut off. Could you hear us?
Yeah.
Okay, I'm gonna actually have Allie take over from here.
Okay.
Hopefully everyone can hear me okay. Let me know if it cuts out on my end. So let me pick up where Emily left off. So just to recap a little bit, the Alameda Contra Costa Medical Association is a professional association of physicians who are committed to addressing health issues of concern to patients and doctors in the East Bay. The East Bay Safe Prescribing Coalition is a community project that is housed in the ACCMA. And the East Bay Safe Prescribing Coalition began as an effort to reduce opioid prevalence by engaging appropriate pain management practices. With that being said, we will now introduce our first speaker, topic of how law enforcement fits into the epidemic. Our first speaker is LD Lewis. LD graduated from Howard University in 1996 and UC Berkeley School of Law in 1999. She has been with the Alameda County District Attorney's Office for 21 years. During her tenure with the DA's office, she was assigned to the Domestic Violence Unit for 3 years. From 2009 to 2010, she was the co-leader of the Misdemeanor Trial Team in the Hayward Branch office. For the last 11 years, LD has been assigned to the Mental Health Unit. This unit handles most involuntary civil commitments for Alameda County, including the sexually violent predator cases, mentally disordered offenders, developmentally delayed persons, persons not guilty by reason of insanity, and Murphy conservatorships. She also coordinated the District Attorney's Office Working Group on Collaborative Courts and Alternatives to Incarceration from 2017 to 2020. In August of 2018, LD was promoted to Assistant District Attorney and became head of the Mental Health Unit. She is currently a technical advisor for the California District Attorneys Association in Mental Health and Law. LD was president of the Bay Area Black Prosecutors Association from 2017 to 2019 and has served on several boards, including the Charles Houston Bar Association, the Earl Warren Inn of Court, and the National Inns of Court Board. LD was appointed to the Alameda County Mental Health Advisory Board in 2017 by the Board of Supervisors and is currently Vice Chair of the Board and currently chairs the Mental Health Advisory Board Children's Committee. Please welcome LD Lewis.
Good morning. Can everybody hear me? I'm hoping that you can. My lips are moving and I haven't had anyone say no, but if I could get a thumbs up, because I know we've had some audio difficulty. Okay. So good morning, everybody. I'm here for just a few minutes to talk to you a little bit about the history of the war on drugs and just put into context some of those variables. So I'm sure as many of you know, this term war on drugs and the focus on substance use in particular started in the 70s. Actually, then President Richard Nixon announced that America's public enemy #1 is drug abuse. And he declared a war on drugs. There was a period of respite from his initial pronouncement under the tenure of President Jimmy Carter, but then the war on drugs was renewed by President Reagan in the 80s. You all might recall Nancy Reagan's Just Say No campaign, which highlighted the dangers of drug use. And it was in the 80s that under the presidency of Reagan that we saw the shift in how drugs were prosecuted, what the sentencing guidelines look like at the federal level, and that type of engagement. The federal emphasis on drug use trickled down to the state level in some jurisdictions. For instance, there was an intensifying of prosecution of drug cases in the state of New York, sort of following lockstep with the efforts of the federal government to reduce the use of substances. Now, as all of you are aware, the war on drugs was not the first time that our country had engaged in some type of a prohibition on substances. We have been started controlling substances in the 1800s, either taxing them or making some substances illegal or harder to come by. But what's noted in some of the there's some public health research done, some historical reviews on how substances have been controlled. And what's interesting is that usually the drugs that were associated with the majority group or the affluent class at the time, those substances were either not controlled at all or lightly controlled. Any substances associated with less affluent groups or people of color were heavily controlled. And so there's historical reference, for instance, to opioids initially because they were associated with or became associated with the Asian community as they were immigrating into the United States in the early 1900s. Those substances started to be controlled under the law more aggressively because of that negative association. Or for instance, LSD, which was associated with the anti-war movement and countercultures of the 60s, started to be more aggressively controlled. And so that then sort of flows this trend that we've had of disparate management of substances flowed into this so-called war on drugs. And so that's where we started to see the differencing in the sentencing guidelines and schedules related to powder cocaine versus crack cocaine, which I'm sure as we all know from just the common discourse, there's no significant difference. You know, the original rhetoric when you heard it in the 80s when the rules were being passed was that crack cocaine was somehow more addictive, more dangerous, but additional science over time reflected that was in fact not true, but it was 100 to 1 in terms of sentencing. So the sentencing guidelines was sentenced by grams, and so powder cocaine was much more lightly sentenced than crack cocaine, which led to extremely long sentences for the population that primarily used crack cocaine, which was the African American community. And so African Americans were receiving astoundingly longer sentences. There's interesting data and facts surrounding the number of individuals who were incarcerated for drugs before President Nixon declared the war on drugs as opposed to after. Those policies that were then Ronald Reagan doubled down on them, significantly expanded the number of individuals that were incarcerated starting in the 70s and then accelerating rapidly into the 80s of individuals who were incarcerated for drug-related offenses. What's also noteworthy about this time period when this war on drugs was initiated is that after Nixon's campaign, it was pretty clear from some of his staffers that the war on drugs was designed to target groups that were problematic for Nixon in his reelection efforts. And so the initial substances were ones that were used by groups that he hoped to marginalize in his campaign reelection, because he consolidated several agencies into what we now know as the DEA, and they were essentially kicking in doors at that time. And because the focus was on select groups that were associated with certain substances, that resulted in a shakeup amongst groups of individuals that were either what he considered that counterculture of the 60s that weren't predisposed to support his campaign, or people of color. That trend continued with a brief respite under Carter, but then was, Reagan doubled down on those policies. One other point that I want to make about the war on drugs in particular in the early days, which I thought was, it's very interesting to read about, is there's some articles that were drafted by public health experts back in the early 1990s, in 1991, the late 80s, and they were all looking at the impact of the war on drugs. So we're talking, 30 years ago, people were talking about the problems with the policies. And this one particular article talked about and put forth the hypothesis that the drug epidemic was not a crime epidemic, it was a public health crisis and should be addressed as such, and made the argument that what we were dealing with was a public health crisis that should be managed in that fashion. And what was interesting is the author talked about prohibition, and that when we prohibit these substances, it can lead to a black market that becomes very violent. And so that author used the analogy of the alcohol black market that led to lots of killing and death, as we all know, from the time Prohibition started in I think it was around 1913 or something like that, until it ended in 1933 with that constitutional amendment. It was, the 20s in particular were very bloody in terms of that black market surrounding alcohol. And the author was analogizing that black market violence to what was happening starting in the 70s when Nixon declared his war on drugs, into the 80s and early 90s, where the black market for drugs was very violent and bloody, similar to what we saw in the Prohibition era. So what has this meant as we've moved into the 90s, the 2000s for law enforcement? I just want to highlight that, in some jurisdictions, the disparities were visible. And so, for instance, here in Alameda County, more than 30 years ago, we started a program which we call mentor diversion, where folks who are young and selling drugs and getting into the drug trade, we tried to divert them away from the criminal justice system with services and programs. Also, approximately 25 years ago or thereabouts, in that same time period, we started our drug court, which was one of the first drug courts in the country to try to provide substance use treatment as an alternative to incarceration for those who were coming in to the criminal justice system for substance use and possession, simple possession charges. And so what in some jurisdictions we started to see in response to some of these policies were efforts to do what the legislature was not willing to do, which was come up with alternatives to incarceration for this population, which we thought might be better served by public health interventions. In more recent years, we've seen an explosion in about the last 10 or 15 years in alternatives to incarceration treatment courts. We have a number of them here in Alameda County. We have the most treatment courts in our county of any in the state. And also we've now begun at the beginning of this year, a navigation center that's a pre-charge diversion program where law enforcement, when they come into contact with someone who's having a mental health or substance use crisis, they can take that person to our navigation center instead of to jail. And we work to connect the individual to public health services in lieu of filing the criminal charges. And that's our CARES Navigation Center. And so the trend is strengthening to move individuals away from the criminal justice system and into public health services. And I think that is what we're seeing more so now today in the transition that the so-called war on drugs is undergoing right now. And so I think I'm about at time. And so I want to see if individuals have any questions.
You could utilize the chat function or raise your hand if you have any questions.
Well, I want to thank you for these few moments to talk about these topics, and I can come back or be available for any question Q&A session later in the presentation. Thank you.
Thank you so much, LD. It's wonderful to hear your perspective. So now we will transition over to our next speaker, who will present on harm reduction and its relevance to law enforcement. Michaela Jones is the Overdose Prevention, Education, and Naloxone Distribution, or OPEND, Project Coordinator at the HIV Education and Prevention Project of Alameda County, also called HEPAC. As the OPEND Coordinator, Ms. Jones works towards lowering the barrier of access to Narcan, creating additional access points through countywide partnerships, as well as trying to incorporate more teen-focused prevention and education. She has worked in public health for over 6 years, having spent much of her time working with individuals experiencing homelessness, mental health, and substance use disorders. Please welcome our next speaker, Michaela.
Hi, my name is Michaela Jones. I am the Open Coordinator with HEPAC, and today I'm going to be taking you through harm reduction and law enforcement. This is going to be a short and sweet training. It's just about 30 minutes, so we're not going to go too in depth on any of the information, but it'll just be a teaser for what harm reduction really is and how it can be beneficial for law enforcement. First and foremost, for those of you that are not aware of who HEPAC is and what we do, we are one of the longest standing needle exchange programs in the Bay Area. So syringe access is really what we do. It's what we started in 1992 and have continued doing since. But over the years, we have definitely adapted to add more to our program. So not only do we do syringe exchange, which allows folks to come and get sterile needles and sterile injection supplies, but we also offer sterile smoking equipment, safe sex equipment. We give out snacks. We have an herbalist and an acupuncturist at our exchanges. And we also partner with a few different health organizations at all of our exchanges so that folks can come and get medical care if they need it, have access to medication-assisted treatment, and a whole bunch of other things. So on top of all of that we do just at our needle exchanges, we also do HIV and Hep C testing and screening. We run a drop-in center, which allows folks to come and take a shower, do laundry, have a hot meal, and just have a place to sit that's off the street for a little while. We do outreach, so we do typically a minimum of 6 outreach shifts per week, and that's all around the Oakland area. So that's a really great way to interact with folks in the community, and we'll hit up encampments, we'll hit up parks, sides of roads, really just wherever we think needs attention. And then if folks tell us that there's an area where folks are in need of services, we'll go there as well. And then one of the last pieces that we do is my program, so overdose prevention education. So I'll go throughout the county, train folks on overdose prevention, work to get Narcan access, and we do that a lot at our syringe exchanges as well, so that folks who are using drugs can have access to Narcan. And then this last piece is the COVID-19 testing, which we added in response to COVID, and we were doing that out of our drop-in center as well as at the exchanges. So just an agenda for today. Again, this is a very short and quick presentation, so we're not going to be able to go really in depth on a lot of these topics, but it's just to really touch over them and have you understand what harm reduction is, some benefits of using harm reduction, how police and law enforcement can actually use harm reduction as a tool, what some future of policing and harm reduction already looks like and can look like for the future. And then the last piece that we're going to go through is how to use Narcan. I'm sure that some of you already know how to use Narcan, but just in case you don't know, I will make sure that you do. So first and foremost, what is harm reduction? I'm sure you've heard tons about it. Maybe you haven't and you've just heard it being thrown around a bunch, but harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. It incorporates a spectrum of strategies that includes safer use, managed use, abstinence, meeting people who use drugs where they're at, and addressing conditions of use along with the use itself. Now, harm reduction is mainly used with folks who use drugs, but that does not necessarily mean that you cannot use harm reduction in every other part of life. You absolutely can, because there is no universal definition or formula for actually implementing harm reduction. So some folks might implement a few core strategies of harm reduction into their work or into their everyday life. Other agencies are modeled after all of the harm reduction pillars like HEPAC, but it doesn't mean that you have to meet every single criteria in order to be a harm reduction agency or use that model. It just means that everyone can kind of interpret harm reduction in the way that fits their community and their organization. One of the core pieces of harm reduction is putting the person first, which is what we call person-centered. And a lot of times we have person-centered care, which is really just the act of serving someone in this way. And so what it does is it allows the ability for folks to be individuals in life. So every single person is different, which means every single person has a different path, has different needs, different wants, which is true also with drug use and recovery. So a lot of the time we have focused that there is one path to recovery, and that's abstinence only, and you need to do 12 steps and things like that. And those are all great and those are all tools, but that's not going to work for every individual. And so using a person-centered care approach really allows the person to be autonomous, to make their own decisions, to decide what they want, how they want, and how often, they want care, if they want care. It treats people with dignity and respect, and that is at the core of everything that we do in harm reduction. But it also is keeping the door open for people who are most at risk and the most marginalized. And it just really allows for a spectrum of beliefs and behaviors, because again, not everything is going to work for every individual person because people are unique and their care should be unique as well. You'll hear me talk about spectrums throughout today's entire presentation, and that's just because our whole life is based off of a spectrum, and so everything that we do with harm reduction has that at its core. So what does harm reduction really look like with drug use? We've talked about it a bunch, and I'm sure that you heard about needle exchanges, and I told you a little bit before, but one of the core tenets is disease prevention. So syringe exchanges really got started to try to help with reducing the spread of HIV, and that has stayed consistent throughout the years. That definitely hasn't changed, but now we've had a bigger focus and shift on Hep C because Hep C rates have been going up. And then COVID could actually be passed through the use of different materials with drugs. So we definitely want to prevent that as much as possible too. So disease prevention is one of the main things that we do. Overdose prevention as well. So just educating people about the different risks associated with using substances, making sure that they have an overdose plan in place, allowing people to access Narcan, making sure they know how to use the Narcan, and just really going through safer use practices with them as well. That all helps with overdose prevention. So we make sure that we do that. Autonomy is huge. So just like using a person-centered care approach allows folks to just be individuals and make their own decisions, we try to let people who use substances be autonomous in everything that they do. So they get to decide what they want to do with their bodies, which includes drug use. So how they want to use, how often they want to use, how many different drugs they want to use, it doesn't really matter. We just want folks to feel autonomous and know that they have the tools that they need to make those decisions, which feeds right into that next point of education. Education is a huge part of harm reduction, and it doesn't get talked about nearly enough because we try to give people as many tools to put in their tool belt as possible, or toolbox, whatever you want to call it. And essentially, we're just giving people all of the education that we have, all of the support that we have, so that they then can make their own decisions. And, all that we can do is try to educate people, but even if we have a set of best practices, that might not necessarily be the best practices for that person at that time. So it's really just about continuing to educate ourselves, the people around us, people who are using, and just kind of go from there. Right here, right now really refers to allowing people to just be dynamic individuals, right? So we don't put restrictions on how people can get services. So we don't believe in having abstinence only to be able to get services. You don't have to be sober to come and get services. However you are showing up is however we are going to take you, and we're going to give you the support and the resources that we have and that you might need, and allow you to just be yourself wherever you are in that moment. Success is how you define it. So again, really just going back to the fact that people are autonomous beings and they should be treated as such. And so everyone gets to decide for themselves what success looks like, and we don't have to understand or agree with that. And that is very difficult for a lot of people because you might not understand. And a lot of the times it's coming from a place of care, but you have to be able to take yourself out of it to really be able to serve people in the best way. So if someone's version of success is that rather than injecting heroin twice a day, they want to inject it once every other day, and that's what their goal is, and we want to help to try and support them in achieving that, right? So we don't have to, again, agree or understand people's decisions. It's not about us, it's about them. So just allowing people to define success. And then this last bit is that drug use exists on a spectrum. So a lot of the time people assume that just because you're using drugs in one way right now, that that's how it's going to be for the rest of your life. And that's just not true. So speaking of this spectrum, this is one idea of what the spectrum or continuum can look like. And you can really take out substance use and input any other behavior in here. It doesn't have to be substance use. This is just great with trying to map out what substance use can look like. So none or abstinence only, all the way through chaotic. So there's many different ways that people can engage with substances. And just because someone's in a chaotic use right now, which really just means that they have a severe chemical dependence, right? The drug is now impacting their ability to do everyday activities. Just because someone's in a chaotic use right now doesn't mean that they're going to stay there. Most people throughout their lifetime are going to go through this continuum at some stage. So just because you're only using socially doesn't mean that you're always going to use socially, and vice versa. So just really putting this into perspective so that you understand that not every single person has a substance use disorder. That's just what can happen over time, right? But some people might use socially for their entire life and it might never get to the chaotic use stage, and that's okay. But just acknowledging that when you're interacting with folks in the community and you might know that they use drugs, that they could be anywhere on the spectrum, and even on a week-to-week basis, they could be going in and out because it's ebbs and flows. And so just acknowledging that and being aware that people can exist anywhere on this continuum. And so that can just help you in your interactions if you might know where they're falling currently. So we've talked about harm reduction with drug use. And so how does it actually work in everyday life? Because like I said at the very beginning, we talk about it all the time with drug use, but everyone every single day has many things that they do that could potentially cause them harm or be a risky behavior. And so some of the ways that we try to reduce those risks to those behaviors are things like seatbelts, sunscreen, rock salt if you live in a winter climate, wearing a hat outside, wood window covers if there's a hurricane or something like that to try to protect the glass from breaking, the vests that you might wear under your uniform. All of these things are examples of harm reduction in everyday life because, for example, if you're a law enforcement officer and you're going to work every day, it's beneficial to wear a vest, right? Because you have the potential of being shot at, stabbed. I'm not saying vests really help with stabbing all that much, but they can, right? And so it really just protects you from the potential harms that exist. And that's all that harm reduction aims to do. We acknowledge that people engage in risky behaviors in all different types of ways every single day. How can we reduce those risks? How can we reduce that harm in the best possible way? So that's all that we're looking to do. So anything that we do with drug use can really be implemented with every other part of life as well. And then one last thing that I wanted to just point out is that stigma really impacts care, and I don't think that people acknowledge truly how much it does. So you might think that, you know, what you say or what you do doesn't impact people, but it does, and language really matters. And so using even just stigmatizing language can be very, very impactful for people. Less than 35% of adults who have opioid use disorder received treatment in 2019. And of those 35%, it took on average 4 to 7 years for them to even get into that treatment. So all of that is to be said that people who use drugs, especially then who have, you know, opioid use disorder or substance use disorder, it takes a long, long time to get into treatment. And then once you're into treatment, it can be so chaotic because of our system is not necessarily set up in the best way to serve folks who have all of these disorders. And so when you're out and about and you're in the community and you're trying to make connections with people, just try to think in the back of your mind, even if it's not all the time, about how you're having interactions with people, because that stigma can be really lasting. And things that you might say or do can impact someone's ability to even get into treatment, because 4 to 7 years is a long time. If that was to be any other type of disorder in your life, if it was, you know, a heart condition, or I apologize because I live in a very busy neighborhood, but you know, if it was a heart condition and you told someone that it was going to take them 4 to 7 years to get into treatment, what do you think that their reaction would be, right? So, you know, opioid use disorder, substance use disorder are just as serious as any other health condition. And the fact that it takes people 4 to 7 years to get treatment because of stigma is so disheartening, right? So that's something that we really want to try to make an impact on. And we really want to try and shift our views when it comes to drug use and how we help people, because we don't want stigma to be the reason that people aren't getting the care that they need. So what are benefits of harm reduction? I'm sure you've probably assumed quite a few since going through that beginning part of the presentation, but I like to view it as a triangle. Now there's many other things that you could add to said triangle, and you can make it as big as you really wanted it to be. But the way I like to see it is that harm reduction is really at the core of a lot of the things that we do in life. And harm reduction can impact public safety, public health, and just community well-being. And all of these things are intersectional. So they all impact each other. You can't necessarily have great public safety outcomes without good public health outcomes, right? And vice versa. So when I view harm reduction, I really view it as a tool to help all of these other areas in life, and they can really be beneficial. Harm reduction can have lasting impacts on communities and can increase public safety and public health, and we should treat it as such, because harm reduction also allows us to have a great deal of compassion for people, and that in and of itself can be lasting. So some benefits on public health. So harm reduction has been shown to reduce the transmission of communicable diseases, especially bloodborne illnesses, as well as infections, fatal overdoses. But outside of all of that, it also increases access to treatment. So at our needle exchange programs and other harm reduction agencies, they often have the ability to make referrals or have treatment information. So it's always there for people, because we, again, believe in people being autonomous and making their own decisions. So if someone's not ready for treatment now, maybe they'll be ready for treatment in a month. Maybe it might take them a decade, right? But we'll be there regardless, and we'll have the information ready for them whenever they need it. Sterile supplies definitely help with reducing, again, transmission of illnesses, access to medical care. Often there are nursing staff or doctors who are at our exchanges, for example, but they're also at a lot of other needle exchanges. They're at a lot of other agencies that practice harm reduction. So people can actually go and get wound care, they can get prescriptions, they can get testing, they can get all different types of stuff. They also can get social and mental supports. Basic needs can be met: food, water, showers, laundry, things like that. And there's also an increased trust of the system when harm reduction is impacted, because when people are able to come as themselves wherever they're at and get access to all of these treatments and resources, they start to have better trust with the people who are treating them like human beings and treating them with dignity and respect. And so having a better trust of the system actually makes people more likely to go into treatment and to get the resources that they need, because often our system has not been created for marginalized populations, people of color, LGBTQ, people who use drugs, and combine all of those things. And well, the system's definitely not created for your benefit, right? So it's understandable that people have a distrust of the system that has definitely failed them. And we try to change that. So we try to make it so that people can have low threshold, low barrier access to the things that they need, and also treat them with dignity and respect throughout the entire way. On top of that, it also decreases the likelihood of death from using substances, because we are educating folks, we're giving them the tools that they need. Death, of course, still unfortunately happens, but with the use of harm reduction in public health, we definitely see a decrease in the likelihood of dying. And then, of course, the decrease in fatal overdoses as well. The goal is to try to get 0 overdose deaths, which is why we always push Narcan and make sure that everyone has access to it. But unfortunately, it's not always that simple. It's not always that cut and dry, but harm reduction programs have definitely made a huge impact in the amount of fatal overdoses that we have seen. Some benefits on public safety. So all the things that we just talked about can also impact public safety, but 2 little sentences that I think really sum it up well is that a central feature of harm reduction is that law enforcement is not left alone to solve the challenges of problematic drug use, poverty, and homelessness. It increases responsibility on other government agencies and community stakeholders, and decreases duplication within government and burden and blame on law enforcement. So I think often too, when folks look at law enforcement, they're always, painted to be this very negative picture, right? Where we shouldn't trust law enforcement at all. And I don't necessarily agree with that, right? The way that our society is built, the way that our structure is right now with our system, is that law enforcement's going to be around. Even if we're making changes and things are happening, we're still going to have police or law enforcement of some kind. Even if your job and your duty changes over time, you'll still be there, right? I can't necessarily see a society in the United States that doesn't have law enforcement just because it's so ingrained in our society. And so often you're asked to do a million different jobs, right? You're asked to uphold the law, you're asked to be social workers, you're asked to be professional referralists, you're asked to be treatment providers, you're asked to be all of these things that you're not necessarily equipped to be able to do. And so harm reduction really believes in the collaboration and the collaborative effort of serving people. And so doing that allows law enforcement to have some responsibility lifted off their shoulders, right? Because you shouldn't necessarily be the expert in addiction services or substance use services, right? Not necessarily your forte. So harm reduction can really help law enforcement agencies to take some of that burden off of you. It can build trust within the community and the people that you're trying to serve. And by addressing the needs of individuals using drugs, again, it can help with recidivism rates and help you with just your everyday duties and activities. It can help get people into treatment if that's what they're looking for. It decreases improperly discarded syringes, which can be a safety hazard for everyone in the community, but especially folks who are potentially having to pat people down and things like that. If people have places to put them, then they're not necessarily going to keep them in their pockets or laying on the street. They're going to dispose of them properly. And it can also reduce the adverse effects of drugs and drug enforcement. So by acknowledging that substance use disorder is a disorder, it's not necessarily something that people should be arrested for, that aids in how you are able to do your job, how I'm able to do my job, and it makes for just a better overall community and society. So to get a little bit deeper into harm reduction and police and law enforcement, so I understand that the people who are on this call are not necessarily all police officers, you're enforcement officers of different kind. And I wouldn't be doing my job if I didn't call out some of the problematic things that are happening right now. And that's not for me to call anyone out specifically or make you feel bad about the way that you're doing your job or things like that, but it's just calling out the reality of the situation. So we're going to go through some of the negatives, some of the positives, but I want to be able to just talk through some of these things. And it's, again, not trying to make you feel any type of way. It's just to call it what it is. So first thing I wanted to talk about is just our current reality. People who use drugs, who are often some of the most marginalized populations, are still members of the community, whether people want to acknowledge that or not. And people who use drugs, and specifically folks who are unhoused and using drugs, are often victims of crime, or they're victims of violent crime, they're victims of abuse, of assault, and often they're witnesses of these crimes as well. As this quote talks about, a lot of times people are refusing to contact the police, and that's because of how they have had interactions in the past, how they've been treated, and it's usually not a very great experience. Now, that's not to say that every single officer is going to treat someone like that, or that's every possible situation, but it's just that most of the time, folks have current or historical traumas with enforcement officers, and so they'll then refuse to contact police where they actually should be, and that's sad, in my opinion, right? We want to change that. People are less likely to call 911 in the event of an overdose for fear of police responding. I'm sure all of you are aware, but if you weren't, an overdose is a medical emergency, so it should be dealt with as such. And people are afraid to call 911 because they don't want to get arrested. They don't want to have to deal with the repercussions that could come from police responding. And people often associate 911 with police, not recognizing that when you call 911, you can also get connected to medical services and fire, right? And so people are less likely to call in the event of an overdose just because they're fearful of what the police might do when they get there. And that's something that we are 100% trying to change, because we want people to feel comfortable calling 911 if they're in an emergency of any kind, right? Like, people deserve to get the care and the treatment that they need. But if people are afraid of what's going to happen when they call, then that's something that we need to look at to try to make differences with, right? Like, we want to make that better. This last piece is incarceration and prosecution does not deter recidivism. So I think that someone later in this series is going to talk about compassion fatigue and things like that. And often you're going to get that when you're seeing the same people over and over again, having to have the same conversations, or you're arresting the same person over and over again. And that's because when you're arresting people, it doesn't do anything for substance use disorder. Just making someone sit in a jail cell for weeks, months, or years on end because they've been using drugs, it's not actually going to help them. It's not going to do anything to treat whatever underlying situations they had going on that were leading them down to using drugs like that. Not every single person who uses drugs has a traumatic history, but a lot of people do. And a lot of people might self-medicate or medicate to try and heal some type of physical, mental, or emotional pain. And so just sitting in jail is actually not going to do anything for those folks, especially if you're not getting resources and support while you're in incarceration. So we know that this does not work. We've known this for a while, and we're starting to make shifts with how we treat people who use drugs, but it's still not necessarily 100% there yet. And one thing that I just wanted to point out is that there's actually tons of overlap between harm reduction and law enforcement. So one of the core tenets of law enforcement is to protect and serve, right? And harm reduction aims to essentially do the same. We don't necessarily phrase it like that, but we all want the same thing. We're trying to save people's lives. We're trying to engage communities, build partnerships, make people feel comfortable and safe. We're trying to protect vulnerable communities. We, especially as a needle exchange agency at HEPAC, deal with some of the most vulnerable folks, the most marginalized, right? And so we're trying to help some of society's most vulnerable and protect them at that as well. Also trying to enhance livelihood. Most harm reduction agencies are really looking to do this piece too, right? Of how can we make everyone's life better? How can we change these communities to make them more lively, to help them with whatever they need? Try to reduce risks. So there are different risks associated with drug use that we can try and help with. There's different risks associated with society, right, and how we act. And so law enforcement tries to help aid with that as well. And this last piece is really just supporting communities. It's one thing to just engage communities and try to build those partnerships, but it's another thing to actually try and sit back and support them. And I think that that's something that harm reduction agencies and law enforcement actually have a lot of overlap with, because as much as law enforcement often are engaging with folks at one of the most stressful times in their life, right? You don't necessarily want to call the police, you don't want to have to call 911, but there can be a lot that happens after you do. And if you're doing your job to the best of your ability, you're often trying to support those individuals or those communities. And you might make referrals, you might make phone calls, you might go and check up on people and do wellness checks, right? And harm reduction does a lot of that too, where we're really trying to support people and see what they need and how we can assist. So some ways that you can incorporate, again, because this is such a short little period of time, we can't get super in depth into all the different ways that you can incorporate. That could be a whole day or 2 day long training, but these kind of go from easiest to more difficult, I would say. So one of the things you can do is attend a training. This, for example, could be your first of many, hopefully, right? Hopefully you take this little 30-minute segment and it inspires you to attend some more trainings and learn more. Would love that. And that's a great way to try to incorporate harm reduction into both your personal and professional life. You can try to use non-stigmatizing language. Again, it's easy to just say that words don't hurt you and they don't matter and it is what it is, but stigmatizing language has made a huge impact in how people receive care, how they seek out care, how they even talk about themselves or the things that they're going through. And so trying your best to not use stigmatizing language can be one of the easiest, most simple and impactful things that you can do. Try to challenge your own biases and stereotypes. We all come to the work that we do from different lived experiences, and so it's easy to pass judgment on people, and a lot of times we're passing judgment because we don't understand. So maybe ask more questions, maybe get to know people around you who use substances, ask them why, ask them what's going on, right? Try to challenge yourself as to how you see people. I know that as a trained law enforcement officer, you kind of have to feed into some biases and stereotypes. That's what you're taught. That's kind of how you're trained to do things. But try to challenge some of those things because they're not always 100% accurate and they're not always true. And so how can we try to overcome the stigma that we feel towards people who use drugs? And how can we overcome that and see the people that they really are? Another thing you can do is partner with local organizations, public health departments, other first responders, treatment facilities, things like that. Try to have more of a coordinated response. That really comes from partnering with other folks around you. Carry and distribute naloxone. So this is a huge thing that departments across the country are starting to do, which I think is great because since police are also first responders, you can also use Narcan. Most of the time, overdose reversals are happening by folks who use drugs, their friends and family members in their communities, but it's still great for first responders to carry Narcan or even distribute it. There's leave behind programs where you could leave them at the scene of a non-fatal overdose or things like that. And those are really easy to do, especially in the state of California. If anyone wants information on the naloxone distribution project and how your station or your district could carry Narcan, definitely reach out to me because I can help you to make that happen. But that's another semi-easy lift. The worst thing that you have to do is get trained, right? And it's not really that difficult of a training. I could also help you out with that. But that's a great way to incorporate harm reduction into your strategies. And then one other one that I like to point out is just making referrals instead of arrest. So there's tons of diversion programs that are happening across the country, and they're seeing great success with that. And a lot of the times when we talk about compassion fatigue and wanting to help people, but just not understanding how you can do it, referrals are a great way for that. Because if you're referring someone to treatment instead of arresting them, that's huge because that allows them to get resources that they need. If you're even making referrals to like their doctor, right? If you know that they have some underlying medical condition, great, awesome. But again, just to really drive this home, arresting people who have a substance use disorder or use drugs, it's not going to do anything but make life more difficult because if you have something on your record, it can be more difficult to find employment, to get housing, to get into treatment programs sometimes. So arresting people actually just causes a little bit more barriers to them actually getting help and getting another foot forward in their life. And then I touched on this before, but the coordinated response teams or hubs can be really helpful for that coordinated effort between different agencies. And I just wanted to point out some examples from around the US that are starting to incorporate harm reduction. So when we talk about the future of policing and harm reduction and how those can overlap and what that looks like. So these are just a handful. This is not a comprehensive list. There are so many that are not included in this, but this is just to show you that there's so much work that's currently being done around the United States with police officers and how they decide to do their policing. So the LEAD program in Seattle, law enforcement assisted diversion, helps with folks that are, would have low-level petty drug charges or things like that. It helps get people into treatment. Boston has a post-overdose response team, which is a collaborative effort between Boston Fire, Boston EMS, the Mayor's Office of Recovery Services, and their police department. So they'll go and actually do a knock and walk, or walk and knock, however you want to say it. And they'll follow up with people after a non-fatal overdose, and they can help get people again into treatment and have them get resources, leave Narcan. Boston also has a police street outreach unit, which has officers who are trained in recovery coaching, and they go along with nurses and social workers and things like that. And so that unit has definitely been really successful. These last 3 to 4 are either resource hubs or have been implemented in multiple areas in the United States. And so these, you could even just Google them and it takes you to their website, but they're great areas to learn more about how law enforcement can actually start to change simple ways that they're operating and have huge impacts. The hub program is something too that was started in Canada and then has been implemented in the United States in a few different cities, and that allows organizations from across different networks in the same part of the city to get together to really look through people that are at risk. And so it's just ways that you can come together in a collaborative effort to try and help people in your community. And a quote that I really, really like is essentially saying that when it's implemented, these programs reduce the risk of HIV and drug overdose, protect the health and human rights of communities, right? So we are trying to protect our human rights, protect people's health, try to make sure that their risks have been reduced and try to just help them in the best way possible. And having a collaborative effort is one of the best ways that you can do that. So if anyone has any questions, I'll be on at the end of this to talk through any questions that you have live. And then if you felt more comfortable reaching out to me via email or calling me or texting me, that's fine too. That's my cell phone number. So if you want to call or text, feel free. And then if you wanted to talk more in depth, maybe schedule a one-on-one, schedule some time for some separate training or something like that, please don't feel hesitant. Just reach out to me. I'm more than happy and more than willing to give these trainings out to anyone, and we can do more in-depth harm reduction trainings too to really talk through what that would look like to implement for you all at your organization or station. But yeah, so that's me. I'm Michaela. Hope you enjoyed this presentation, and if you have any questions, feel free to reach out. Thank you.
Welcome back, everyone. We are a little over on time, so we're just going to take a quick 1-minute break. We can come back at 11:55, and we'll pick up from there. All right, that was a short break, but welcome back, everyone. We're going to jump right into our next topic. So our next topic is tools that are currently being utilized by law enforcement. Our next presenter is Mark Karanding. Mark has recently retired from the National Guard's Counter-Drug Task Force, a career 21 years in the making. His last duty assignment was with the Northern California High-Intensity Drug Trafficking Area, also known as HIDTA, as the Drug Demand Reduction Coordinator. Understanding fully well how his career has come full circle from dismantling the supply of illicit drugs to reducing the demand of it, he knows more is yet to be done. Mark was just selected to become the Drug Intelligence Officer for the Northern California HIDTA and will continue with his efforts in advocating for and supporting drug prevention activities within the Northern California HIDTA area of responsibility. Please welcome Mark.
Hey, thank you so much, Alejandra. Can you guys hear me okay?
Yep, we can hear you.
Okay, perfect. Let me just share my screen real quick. And are you guys able to see my presentation?
Yeah, we can see it.
Okay, cool. And it's the presenter mode, right? Not with the notes. I tend to do that often.
Yeah,
Nope.
you're good.
It's good to me.
Appreciate it. Thanks for the kind words, Alejandra and David. Good afternoon, ladies and gentlemen. I hope everybody is doing well. Before I get started, I want to invite our director to provide some opening remarks. Our director's participation in these events really highlights how important it is for top-down command support in these types of collaborative efforts. And we're lucky to have both his support and vision in making our communities stronger and safer. The Executive Director of the Northern California HIDTA and Regional Intelligence Center, Mike Sena.
Hey, thank you, Mark, and really appreciate the opportunity to talk with everyone. You know, an important part of the Office of National Drug Control Policy's efforts to deal with, drug abuse, addiction, as well as the enforcement capabilities that we have in law enforcement is, put together with the HIDTA program. In our area, we are responsible for 13 high-intensity drug trafficking area designated counties, and for bringing together federal, state, local, tribal, and territorial resources so that people work together collaboratively. And we do understand that, the issues that we're dealing with especially with the opioid overdoses and fentanyl and the increase we've seen, especially over the last year, is not going to be resolved by, just arresting people. It's a whole community approach. And that is why, we're lucky to have Mark Karanding as our, intelligence professional and prevention professional here within the Northern California HIDTA as a resource to all of our law enforcement, public health, and our public service and our community organizations to help build those bridges to identify the threat, to provide resources to mitigate the threat, and to help folks that need assistance from all of our services combined. So I'll pass it back to Mark, but I really appreciate your work today, and thank you for your time for being on this call. Thank you, Mark.
No, thank you, Mike. Excuse me. So, who do we have to call? I'm just curious. David, do you mind pushing out that first poll? As a presenter, always interested in knowing who's in the audience. I also like to feed off the energy of the audience. It's very, very hard to do that through Zoom versus in person. But what you guys can do to let me know that you guys are alive and well is maybe send some shout outs on the chat, or even just bombard the screen with emojis. That'll certainly help me get more excited for this presentation. It really is a wonderful Wednesday. We've already heard from two very, very great speakers, LD and Michaela, who really talk and discuss about some very, very important core issues that's really, really important to our communities at large. And these are great awareness for our law enforcement sectors. So we're here to talk about law enforcement's role in tackling the opioid epidemic. I'm curious, for the folks on the call with us who are able to participate via chat, kindly jot down a couple sentences about what you think law enforcement's role in tackling the opioid epidemic. I'm curious to know, because later on in the presentation, we'll go back to what you guys chat or typed in the chat, just to see what your all's understandings or feelings about law enforcement's role in tackling, the opioid epidemic. And let me start by saying, the greatest threat to public health and public safety by far is a social issue which has impacted countless generations of Americans, which continue to kill more Americans than all of our modern wars combined, and which continues to impact our communities, whether it's on our main streets, rural America, inner city streets. There is no community that is not shielded from the greatest threat to public health and safety. And that, ladies and gentlemen, is addiction. Real quick, the high intensity drug trafficking areas, or HIDA, is what we like to call, is really a nationally grant funded program under the Office of the National Drug Control Policy. And really, for a county or for an area to be congressionally approved as a HIDA region, three things need to exist. Number one, there needs to be a negative impact to the community from drug trafficking and/or production. Number two, the area has been identified as a major drug trafficking hub or a major producer of illicit narcotics. And three, probably, in my own opinion, the most important aspect of the HIDA program, and really what sets us apart from the rest of the other federal drug control programs, is that local law enforcement agrees to provide resources in personnel to disrupt and dismantle drug trafficking organizations. You see, without this local law enforcement buy-in, we are not going to be nowhere near as efficient and effective in addressing our community-rooted drug-related issues. It is the last part that makes the HIDA program so successful, is this local buy-in. And one thing I wanted to point out, California is very unique compared to the rest of the country. We have 4 HIDA regions in the state. Whereas, some HIDA regions cover down on multiple states. And really what this underscores is just how much of a drug trafficking problem we have in the state of California. We have 4 designated HIDA regions, and I believe equal amount of fusion intelligence centers as well. And here's a little shameless plug. If you're not already part of our law enforcement, vetted partners, we encourage you all to sign up. nickrec.ca.gov for our particular HIDA and fusion center. I understand we have law enforcement folks from across the state, probably across the country, but understanding what is happening in Northern California, provides greater situational awareness of what is happening regionally, as well as statewide. All the HIDAs in California and all the region are the fusion centers in California have their own web pages where you can sign up. Again, for us particularly, nickrec.ca.gov, brand new partner login. And one thing that we've done recently is, understanding the critical need of a collaborative approach to our national drug control problem, which, encompasses law enforcement, public health, and safety partners. We've opened up memberships to the other sectors as well. For law enforcement specific, as a law enforcement vetted partner, you would gain, law enforcement related intelligence bulletins, which really is just to make you more aware, more efficient, and safer law enforcement officers. A couple examples is our annual threat assessment, which we submit to Washington, D.C. on an annual basis, which provides a strategic law enforcement centric viewpoint of concerns about drug trafficking issues within a area of responsibility. Another such example is our quarterly bulletin. We have 21 drug task forces as a part of our Northern California HIDA. And what we try to encompass during our quarterly bulletins is some of the cases that these drug task forces have been successful in dismantling. For our non-law enforcement folks on the call, we also push out non-law enforcement sensitive public health and related information as well. And really what we try to do is create a platform where we're able to share information and intelligence in order to make our communities safer and stronger. So, we're here to talk about the opioid crisis. It's not a single, it's not by all means a single problem. It is a health crisis. It's both a criminal justice crisis and a human services crisis. The pervasiveness of opioid addiction or opioid use disorder and the rapid increase of fatal opioid overdoses have received the most publicity. But there are many other consequences, such as physical and psychological harm to children, losses in economic productivity, significant cost to Medicaid, strains on state and local criminal justice, and child welfare systems. And so really, the opioid crisis is much too large to understand or to address from just one perspective. That's why training such as this is incredibly invaluable in order to gain a greater self-awareness, but also to promote interagency and cross-sector collaboration. So California, how are we doing in California in terms of the opioid epidemic? From our viewpoint, from our law enforcement centric viewpoint, not so good. The reason why I say this is because 2020, again, has already been a record year in terms of illicit seizures that our law enforcement sectors are involved in. We are seizing more fentanyl to kill every American in the country many times over. And, really, this correlates to our rising drug-related overdoses in the state. A couple years ago, California was, somewhat, we fared better from the opioid epidemic as compared to the other parts of the country, which have been hit hard by the current opioid epidemic. Part of that reason is a combination of multiple factors. Our harm reduction efforts in California, bar none, very forward-leading in the nation. We've had drug monitoring prescription programs, PDMP, in place for a lot longer than a lot of other places, in the country. And also our sources of illicit drug supplies, really were not conducive to the fentanyl, to the fentanyl phenomenon, as what we call it. And so, this is about 10 years ago. Now something's changed where, the three factors where I've talked about, PDMP through cures, our harm reduction efforts, and our sources of heroin are no longer shielding the great state of California from rising overdoses. What we're seeing are drug cartels, expanding, diversifying their portfolios, if you will, in order to meet the insatiable drug appetite problem. These drug cartels, drug trafficking organizations are profiting off of addiction. And for every ton of fentanyl powder we seize, how many more tons of fentanyl powder makes it through the hands of law enforcement? So two objectives, for the next 15 or 20 minutes. The first one is to really encapsulate what we're trying to accomplish this afternoon. And that is to inspire and motivate law enforcement to be active participants in community-led efforts in addressing the community drug problem. David, do you mind putting out that other poll? I'm curious to know if you are involved in any interagency, cross-discipline collaboration in addressing community drug problems, yes or no? All right, cool, Dave. Yeah, it should be the second poll question. Really, this is. I'm hoping everybody answers yes. You guys are involved in some level of community collaboration in addressing our drug problem. That's what we like to see. Yes. Unfortunately, I I believe through our work with several community-based organizations, law enforcement and community-based organizations, by and large, really have a long ways to go in effective community-based collaboration and cooperation. And again, the reason why I'm saying this with confidence is because our state's overdose rates has increased dramatically. And so our next talking point is promoting data sharing through ODMAP. My next poll question is, who's all heard of ODMAP? I'm quite curious to know your level of understanding of ODMAP, or whether if you've heard of the program before. So going back to inspiring and motivating law enforcement participation. Why should law enforcement be active participants? Quite simply put, this is from a Gallup survey that the New York Times had pushed out. For the first time in its 27 years of measuring attitudes towards the police, Gallup found that a majority of American adults do not trust law enforcement. The majority of Americans do not trust law enforcement. So this is pretty important, right? Because this level of mistrust, breeds anger, emboldens criminals, and prevents cooperation. We are now in an environment where two individuals are ambushed in broad daylight just because of the uniform they are wearing. And if you don't recall, this is from the Los Angeles Sheriff's deputies who were ambushed in LA a couple of months ago in broad daylight. They're just minding their own business and viciously attacked. This is the type of environment we are in when there's mistrust between the community and law enforcement. This level of mistrust, results in the direct degrading in public health and public safety. And we're seeing it through the increases in violent crimes. It's one wouldn't have to delve too deep into understanding the civil unrest movements last summer in regards to increases in violent crimes. And LD did a great job of briefly talking about it this morning. Just to recap on some of her talking points, this negative attitude towards law enforcement, obviously did not manifest itself overnight. It has been decades in the making. And so our nation's, racial injustices and inequalities will always be a stain to our history, and was made much more worse in the 70s when the war on drugs was declared. And if you don't recall the time period before the 70s, the war on drugs, this point in American history, the civil rights movement. And if you think about it, immediately after the civil rights movement, when we thought we were making great headways in civil rights, the war on drugs was enacted. And so there's been a constant cycle of epidemics, since then, crack epidemic, we had the meth epidemic, and now the opioid epidemic of the early 2000s. And so the sole reason law enforcement should collaborate in community-led efforts in addressing the community problem is quite simple. Collaboration regains trust. Collaboration regains trust. I wanted to spend a couple moments on this photograph, and I wanted to garner some feedback or some of your thoughts about what you all see in this picture. Please feel free to just type it in the chat. What do you guys see in this picture? This picture is incredibly powerful for a multitude of reasons, especially, about what we're talking about so far with our history with the drug war, harm reduction. What is it that you all see in this picture of a San Francisco police officer? By the way, this was taken right outside of our office. And really it encapsulates the evolution that Michaela was talking about earlier. So I'm seeing somebody say empathy. Rob, thank you so much for participating. Stephen, role of OND, harm reduction in law enforcement. Excellent. Anybody else? Copper trying to connect with subject, not just enforce, harm reduction, not enforcement. Would you guys agree that we've seen almost a 180 from law enforcement's response in the 70s to now? Our national drug control strategy 5 decades ago. Do you guys recall what our national drug control strategy was 5 decades ago? If you use drugs, you're going to jail. If you sell drugs, you're going to jail. There's no treatment options for folks suffering from a disease in which we know a lot more about today, and that disease is addiction. Thank you so much for all the comments. You guys are all absolutely correct. You know what we're seeing is really law enforcement's role moving forward. So this role, I spent a couple minutes talking about is how do I say this? It's very difficult to understand, to say the least. You know, law enforcement's role in the responding to the opioid epidemic. I'm gonna scroll up to just see some of the chats that you guys okay, so earlier I asked, what you all thought about law enforcement's role in responding to the opioid epidemic. Tony, collaborating and finding routes to treatment, ideally, absolutely. US CBP, stopping the flow of drugs, securing our borders to make sure that we don't get fentanyl across the borders. Preventing the introduction of dangerous drugs from foreign sources. Understanding what drugs are being used in our area and why. Investigating overprescriptions and patient harms. These are all answers that really play into our traditional role of law enforcement, right? Which is essentially just that, law enforcement. Did you, Michaela had mentioned this earlier in her presentation. She had mentioned that law enforcement is the only public health and public safety sector that has to deal in playing multiple roles in terms of the opioid epidemic response. This is vastly different from public health, treatment and addiction sectors. And they only have one role essentially. Law enforcement plays multiple roles, and this is something that they are not accustomed or they are not trained to to do on their own. And so collaborative partnerships with harm reduction folks, community-based organizations, highly important. Training such as this to increase self-awareness, highly important. And just to recap, those 3 roles are emergency response. Narcan is now readily available to law enforcement, and law enforcement is saving if not thousands of lives every day on the streets in America. So that's one role law enforcement plays. Number 2, public safety. We're seeing through a lot of programs like law enforcement assisted diversion programs. Getting folks connected to public health and treatment instead of in incarceration is a very public health and public safety approach. And law enforcement, just like what we saw from the picture a few moments ago, is more than capable of playing those roles. And then lastly, law enforcement, right? And so just to echo what Director Senna had mentioned earlier, law enforcement really is trying to get after the supply that's creating folks to to overdose and die from from a medical situation, which is the #1 preventable, essentially, whether through Narcan or harm reduction efforts. And so, law enforcement is really interested in the folks that are poisoning our streets with drugs that make people overdose and die. So these are the 3 roles that law enforcement officers play. Again, it's a very multifaceted role, very unique to law enforcement, which poses its own unique challenges. So check the blocks here, right? We, hopefully it's able to inspire and motivate somebody out here to be active participants in community-led efforts. David, thank you. 5-minute warning. Next thing is ODMAP, promoting data sharing through ODMAP. And one of the reasons why we're losing the fight in getting a better handle over overdoses is, we just don't have data that helps us respond in an effective and efficient manner. David, do you mind sending out that other poll asking folks if they have access to data that helps them in the course of their duties in responding to the opioid epidemic? And so probably, if not the top 1 or 2 single contributing factor outside of fentanyl being so readily available is having access to overdose data. What we're seeing is we need overdose data in order to know where and how the communities are being impacted. And so the HIDA program developed the overdosing mapping application program. It's a free program. We're not gonna have too much time to really go into the weeds in this, but a couple of things I need you to understand. #1, it's a free program for law enforcement and public health. So I'm looking at the results here real quick. Overwhelmingly majority, almost 70% of you said no, you do not have access to updated overdose information to help you in the course of your duties as law enforcement, public health, and or public safety. And so really, this drives the point home that this data is being collected, but is not being readily shared and distributed. The HIDA program is a very successful business model. It's founded upon the sharing of information and intelligence, and we created ODMAP. And so ODMAP gives us the ability to track overdoses in near real time to be able to see spikes in overdose clusters in our communities, so we could direct the very finite resources to the impacted areas. Essentially, you have the ability to input overdoses as they are occurring through your smartphone or through your computer. And then you're able to analyze that information in near real time to direct messaging, to make sure that EMS and law enforcement personnel, that there is an increase in overdoses in the area, to make sure our harm reduction partners are aware that there's increasing overdoses in the area, to make sure all of our public health and safety sector partners are better prepared to deal with rises, overdoses as they're occurring. Because what we're trying to do is to prevent the situation from getting worse. So this is an actual video of how long it would take a person to input an overdose, a suspected overdose in real time using their smartphone. It takes no more than 10-15 seconds generally. And so, multiply this effort, hundreds and thousands of times within a geographic area or even, a state, and we will get a better picture, more up-to-date picture of just how bad drug overdoses are impacting our communities. Right now, current overdose data lags behind 1 to 2 years, and this is both at the CDC federal level and the state health department level. It's just the way it is. Public health data is not as near real time as we would like, as compared to what law enforcement is used to, which is actionable information in order to further ongoing investigations. So just real quick, these are M30 pills, Oxycontin pills. What's very different about these pills is they're counterfeit. One wouldn't be able to tell because they look like regular Oxycontin pills. They have the M30 stamps. The only main difference between the real ones and these ones, which are fake, is that fentanyl has been introduced into the pills. And so Monterey County is what we use as an excellent case study of ODMAP and law enforcement, collaborative responses is quite simple. We need to get everybody on board and looking at the same data and responding accordingly. So those M30 pills, which we saw a lot in Monterey County, it was law enforcement concern. It was a public health concern. We had tremendous partners with the hospital in Monterey. They had reached out to us and said, hey, we are having lots of overdoses in Monterey County, which we are not accustomed to seeing. And they asked for help in getting ODMAP set up in Monterey County. I asked for the overdose data. I started inputting this data into ODMAP. And what we're able to highlight and demonstrate here, ladies and gentlemen, is an immediate threat to public health and public safety in Monterey County. The reason why I say an immediate threat, because in 2018, Monterey County had 9 overdose-related fatalities in 2018. 2019, this data is from 2019, Monterey County almost has 100 overdose-related fatalities. So going from 9 overdoses 1 year to 100 overdoses is a problem and is an issue, which is not unique to Monterey County, and is actually what we're seeing in all other 58 counties in the state, which is increases in overdose rates. And without ODMAP, we wouldn't be able to to really get a better understanding of just how bad our communities are being impacted. Because I'm gonna be upfront with you now, data that's 1 to 2 years old does not promote an effective response. You need near real-time data to be able to assess what is happening in the communities. So we are just about done. A couple resources I want to share with you folks is ODMAP.org is where you want to go to sign up. Anybody on this call can sign up to get an account. They respond pretty quickly. And then the last thing I wanted to share with you folks is, so we talked about, the last thing I want to talk to you is whether or not I met my objectives as a speaker. First thing is, inspire and motivate law enforcement to be active participants. The goal is to continue or begin to support community-led efforts, from a law enforcement, public health, and public safety framework. The second thing is ODMAP. We did a survey statewide. We had over 200 law enforcement sectors participate, and this is quite alarming. These are law enforcement agencies using the ODMAP program. Almost 90% said no or unknown. And really what this means is there's a missed opportunity here for law enforcement to collaborate with public health in a program to be able to track overdoses in near real time. And then our last bullet is promoting data sharing through ODMAP. Our goal here is for you all to be advocates for ODMAP within your own agencies. As a little side nugget, the 4 California HIDA programs in the state of California is currently working with a legislative law policy organization out of Washington, D.C. To draft statewide legislations to make ODMAP statewide law, essentially. We are following the model of several other states which have passed statewide laws, and we're hoping that within 2 to 3 years time frame, ODMAP is a companion to our Cures 2.0 law, which makes prescribers bound by law to input all of their prescriptions, their cures, followed by EMS efforts and law enforcement efforts to put all suspected overdoses in ODMAP. I know we didn't get a lot of time to talk about ODMAP, but if this is something that is interesting to you or your agencies, please feel free to reach out. Here's my contact information, mcaroning@nicric.ca.gov, or give me a call, shoot me a text, whatever you all need, we are here for you. Thanks again, and I apologize in advance if I went over. David, Alejandra, I'll turn it over back to you.
No worries, Mark, and thank you so much. All right, so we're going to move on to our next presenters now. Our next presenters will discuss their experience going through the system from a substance use disorder recovery perspective and from a family perspective. Our first speaker is Nick Baltazar. Nick is a member of the Speakers Bureau and an outreach director at the National Coalition Against Prescription Drug Abuse. Nick is an avid advocate for education on substance use disorders. He uses his personal story to provide insight into this disease and how prescription drugs can have the danger of producing substance use disorders. Please welcome Nick.
Hi, thank you for having me. So my name's Nick Baltazar, and I am joining you guys here. I'm really glad to be participating in this to share my personal story, as I am in recovery right now and had severe opioid use disorder and post-incarceration. And I just wanted to begin giving a kind of a really quick background on how I became, how I acquired this substance use disorder. I started taking OxyContin for a surgery that I had. I had injured my hand really bad, and a surgeon had to put my nerves and tendons back together so I could use my hand again. And this was back in 2011, and they were a little bit more cavalier with the prescription of opioids then, and there wasn't much patient education. Basically, oh, you're welcome. I'm happy to be here. Basically, the surgeon gave me a 3-month supply, which was 300 oxycodone pills, with one sentence, which was, "This may be habit forming," as a caution, which I felt was, at the time I didn't know, but in hindsight, that was just incredibly insufficient education-wise. So yeah, I needed the pain medicine because I was in severe pain, but it was too much to have at once, and there was not much education around it. I progressed into becoming physically dependent on it, while at the same time, in an insidious way, was becoming psychologically addicted to it, and was in a pretty profound denial about that aspect of it. For 5 years, I became addicted to opioids, and went from basically taking these oxycodone pills all the way to using IV heroin and fentanyl. And long story short, it destroyed my life. It slowly pulled my identity apart, and the priority of getting and using these opioids just climbed to the top. To give people who have never had an experience with any kind of addictive behavior, gambling, compulsive buying, purchasing, it can be more than just substance use. It hijacks a part of your brain that's there to reinforce survival behaviors, and that part of your brain is the same one that compels you to blink. So if you try not to blink, you can actually safely not blink for a long time, hours, but it's very hard not to. And so the priority of using the drugs got to this level where it felt like if I didn't use it, I would die. And it's not that I was suicidal or wanted to end my life. That was never an intention, but it had become so important to me that I was risking my life to use it on a daily basis. So after 5 years went by and I slowly decomposed into, a shell of myself with imprisoned in my own mind, basically. I was finally arrested and went to jail and spent 11 days in jail. In the incarceration experience, I'll just touch briefly. I'm going to talk mainly about my post-incarceration experience, but while in jail, it was a very terrible experience. Basically, I was cold turkey withdrawing, and the officers that were, the guards were basically telling the doctors and nurses that I was trying to see that I was faking it. I was taken care of by my bunkmates during those 11 days as they made sure I was hydrated and poured Gatorade into my mouth, and could barely get up. I finally got an amazing opportunity. My lawyer worked with the judge to negotiate my release, pre-trial, pre-sentencing, into a recovery program, a residential rehab, which was a very, very strict rehab facility, but still, it had a door. I could leave at any time if I wanted to, but I would be immediately expelled from the program. When I got there, I was very happy to be out of jail, but I was still, my identity was shattered. I had built, over 5 years, I had replaced my identity and sacrificed my values for this other thing that I became. And when the numbing effect and the fog of using finally cleared, I experienced a flood of all of the things that I had been running from, and those things had been building for 5 years. It involved dropping out of medical school. It involved, committing crimes, basically, to sustain my habit, and doing things in my entire life. This substance use disorder it started when I was 27. So my adult identity was gone and replaced by this other thing, and feeling lost and feeling like hopeless and helpless at first. It actually was the safest place for me to be, was in this residential rehab. And the fact that law enforcement and the court system was able to create this possibility for me was, it saved my life. And I remember that we had this practice. One of the things, I could talk for a long time about this, but one of the things they had us do there was write a gratitude list of what you're grateful for. And at first it felt like, well, my life's over. It feels like my life is over. And looking back now, that was 3 years ago, and I've been clean for 3 years. That was my second chance at life. Like, I literally survived a terminal illness, and that was the start. My life was not over. It was just restarting. It was beginning again. And by the end of the 3 months at the residential rehab, I put at the top of my gratitude list being arrested, which was kind of like, I was like, felt weird about it, but it was true. Like, I could feel that finally giving myself a chance to get off of the drugs and being forced into recovery, forced by the system. Yeah, I had the option to leave, but the consequences, the legal consequences, were immediate, and there was no way to stay in denial about it. As I left that program, I transitioned into another 1-year outpatient program as I awaited my sentencing, and got very involved in recovery, and was able to connect with other people in recovery and socialize and replace that relationship I had with the substance with real people who had gone through experiences like me. So after coming out of jail, my pretrial officer and probation officers were super supportive. They encouraged me. They held me accountable. They they gave me this opportunity, and they really did save my life. Now I have this amazing experience that started as part of my sentence, which was to do community service by public speaking, which I finished in January, and I'm still doing now because of how important it is to me. But I can take, the experience of having that transition into a way for me to actually self-actualize, help other people. I'm not a doctor now, but I am helping other people. And that was my, raison d'etre, so to speak, before, and it still is now. I recover myself. 5 minutes. Yeah. I want to give April a chance to speak, make sure I'm not going too long. The main points are that by getting this opportunity to be in recovery with the help of law enforcement, with the help of the court system, I went from being basically a substance using criminal to a participating member of society, contributing to education that I wish I had gotten earlier before my use started, and hopefully preventing further substance use disorders and overdoses. So thank you for having me, and I'm happy that you're willing to hear the story. And if you have any questions, please let me know. Put my email in the chat. So thank you.
Thank you so much, Nick. It's really amazing to hear your perspective, and for people working in the system to really hear from someone who's been through it. So we really appreciate it. So now we will introduce our second speaker, who is April Rivero. Following the tragic overdose death of her 21-year-old son, Joey, April founded the National Coalition Against Prescription Drug Abuse and has worked since 2010 to prevent prescription drug-related substance use and overdose deaths through community education, policy change, legislation advocacy, and through the distribution of Narcan for at-risk community members. April also leads the Contra Costa County Meds Coalition, which she founded in 2012, and is an active member of several other drug abuse prevention coalitions and work groups. In addition to receiving numerous recognition awards for prevention efforts, April was honored in 2018 as the CNOA's District 1 and Statewide Citizen of the Year. Please welcome Ms. April Rivero.
Thank you very much. I appreciate the opportunity to share our family's story and to also just give you a personal perspective of, not just our family, but countless of numbers of other family members who've been impacted by this prescription drug and opioid epidemic throughout the country. So let's see, I want to be able to share my slides if that's possible, David, and I don't see that they're moving. There we go. Thank you so much. All right, and I'm not being able to advance them, so there we go. Thank you. So just a really super quick overview of our organization. So we're a 501c3 nonprofit based in San Ramon, and as was mentioned in the intro, our mission really is to prevent prescription drug-related overdose deaths and addiction through community education primarily. So I would say at least 95% of the work we do is related to educating every facet of our community, and that would include youth, of course, adults of all ages, including seniors. We do policy change where we can, and I've certainly testified on behalf of legislation at the state and the federal levels. One thing I also helped found was the Fed Up Coalition, and that organization is made up of impacted family members primarily as well as agencies and nonprofits, et cetera, that have been formed from those individuals across the country. And we've been working since 2012 to really drive federal action to make a difference in this, this environment that we're working in. So I could never have expected to be involved in this work at all until that fateful day on December 18th, 2009, when we got a call from Joey's girlfriend, who he had gone to school with at Cal High here in San Ramon, where I live. They were both attending Arizona State University, and we learned that Joey had been found in his off-campus apartment where he lived with a couple of his fraternity brothers, roommates. And ultimately, within about an hour of that call, we learned that he had passed away. And, you know, we couldn't have been more shocked or horrified. I mean, absolutely devastated to get this news just a week before Christmas. We were literally expecting Joey to be home for winter break the next day, and he had a job waiting for him, you know, the following Monday, as he always did when he came home on his college breaks. And, you know, to ultimately learn that, you know, and it took us about 4.5 months to learn this when we got the coroner's report, that he had died from a prescription drug-related overdose. We just couldn't even believe it. Our family did not have a history of even using these medications that could have included sedatives or, you know, stimulants such as Adderall and those kinds of drugs, and certainly opioids. The only thing that I really knew, in fact, about the dangers of prescription drugs was the fact that you could become addicted to opioids. And so the only occasion that I can recall any of us ever being prescribed opioids was when Joey had all 4 of his wisdom teeth removed. And I believe that was his freshman year of college. Came home and we had that done while he was on break. And I remember him getting Vicodin prescribed. And I also very clearly remember putting the Vicodin away and just telling him, here, Joey, here's our drug of choice, Advil. Let's see if this handles your pain. And if so, you know, you don't need to bother with this stuff. If you need it, come see us. But he never did. We gave him a couple of doses of Advil and that was it. So that was my experience with these drugs. You know, dealing with the death of a child, you know, having to bring him home from Arizona, you know, burying him literally the day after Christmas, and, you know, going through the mechanics of all that was just horrifying. But I immediately started focusing on the fact that if we could be so naive, and after talking to friends and family, learning that they didn't know any more than we did about these drugs, I really felt compelled to, you know, get out there and spread the word. Very quickly, I ended up forming the National Coalition Against Prescription Drug Abuse, because I quickly realized that having an organization behind, you know, our story would really help. It would help, you know, with credibility, et cetera. So by June 2nd, 2010, so just less than 6 months later, we did have our organization formed. And because we named it the National Coalition Against Prescription Drug Abuse, that word national, I almost immediately started connecting with, you know, different entities across the country. And that was because they felt, you know, just because of the name, we were huge. We weren't, and we still aren't, but we still have had an opportunity to share information and to gather it and share best practices across the country in a way that I wouldn't have expected. So the collateral damage that happened as a result of Joey's death is represented in this photo. It's the only one I have of these 3 boys. 6 months, let's say, I'm sorry, 9 months to the day after Joey passed away, the one in the middle here died from a self-inflicted gunshot. He shot and killed himself in front of his girlfriend. He died, this is John, he died, devastating again, all the friends, all the people there at ASU that knew him and knew all of, you know, all of these kids. And then as soon as his mother, John's mother, heard that he had taken his life, she tried to take her life. And so the collateral damage was just amazing, the impact on all these kids. And over the course of a year, there were 9 students at Arizona State University alone that I learned about that had either died from an overdose, that was 7 of them, or 2 were suicide, and John was one of them. I came to realize how big a problem this was in the college setting. And of course, by then I had also started seeing and hearing about overdoses from, people around the country. So a big part of Joey's story is, and this is where law enforcement comes into play, is that the doctor that prescribed the medications my son died from 9 days earlier was ultimately convicted of second-degree murder in Joey's case and 2 other young men. You're looking at a photo here on the left that shows that 9 young men had been patients of hers, and over the course of about a 3-year time frame, her prescribing had led to their deaths. So ultimately, it took about 6.5 years for her to be arrested, arraigned, going through a preliminary hearing, a 2-month-long trial, and ultimately the conviction and sentencing that led to a 30-year to life sentence for her. This was a landmark case from around the country. No other doctor at that point had been convicted of a second-degree murder charge, and that was the case for all 3 of them, including my son, and illegal prescribing for the others. So we've been through a lot as a family, and in the course of this, just being there, being able to give my, personal impact story in front of the judge as he was, listening to all of the impact statements from the family members for all of these young people that have been, affected by this doctor. It was just heart-wrenching, just knowing that, there was just a tremendous level of grief. I learned in that session, the impact session, about other parents who had committed to, attempted suicide themselves because they couldn't bear the loss of their CHIP kids. Most of the parents had gone through having their child have addiction problems that led ultimately to their death. That wasn't our story. Just all of a sudden Joey was dead without really any history of this, this kind of thing. But across the country, I've just seen so much impact, parents getting literally ill because of the stress and dealing with the addiction factor for sometimes years and years and years, the hope that comes along with, their child going into rehab, but then next thing you know, it isn't working and they have to literally kick them out knowing that they have no place to go because they're creating such disruption to the family that they can't manage it any longer. I've grown just a true appreciation for those families that are dealing with substance use disorder. And my perception of those who have it has changed completely. I realize now that it is a disease. And, before I just thought, hey, just turn your life around, it's a moral failing in a sense, that was my perception before Joey passed away, but that's changed. Additionally, law enforcement helped take down, and the Board of Pharmacy, of course, this pharmacy that was doling out these prescriptions and basically filling them indiscriminately. Because of this particular pharmacy that Joey got his prescriptions filled at, the pharmacy board has actually established red flag alerts that pharmacies are supposed to pay attention to now, and they're not supposed to fill prescriptions, and they can be held accountable and shut down like Pacifica was if they don't adhere to them. So let's see, I say break time. I have a few more minutes. So what I wanted to share was that the impact on family is absolutely acute. I will never, ever forget my son. Every day I think about him. Most days I talk about him because I share the story and what happened to him. The fact that he died from basically a single pill of Xanax mixed with a pill and a half of oxycodone and a bit of alcohol. He was out with his friends celebrating the end of finals and, winter break before he was going to come home. It didn't take very much to take his life. So I'm sharing that in high school classrooms and just in every way I can. And that's because of the impact. We want to stop young people from moving down this path in the first place. So my advice to law enforcement would be, I know compassion fatigue has to be there quite often. You're saving people time and time again as a first responder. I would ask you to fight against that. There is hope for those individuals that you happen upon. I've seen it happen. Families are counting on you to do the right thing. So where there is a high-level drug dealer, where there is a doctor, of course, or a bad acting pharmacy, we need to shut those down. And prescription drug-related substance use disorder caused by legitimate prescriptions happens most often So I want to make sure that everybody keeps in mind that it isn't a choice. I mean, Nick is a great example of this. He got prescribed because of a legitimate health condition, and that happens over and over and over again. So I want there to be compassion and try to fight against the fatigue of that. And then do what you can to move people into recovery. I love the photo that Mark showed, you know, a very compassionate police officer, you know, reaching out to someone who was clearly in trouble and doing what he could to help. Felonies are convictions ruin lives. You know, Nick is a great example. Again, I hope you don't mind me saying this, Nick, but he wanted desperately to be a doctor. He was in med school, and now he has a felony that I'm not sure he'll ever get rid of. His life has changed completely, and he's a great person. He has so much to offer, and he's finding a new way to do that. But there is hope for those that get involved in this. I think the role of police officers is definitely to keep these drugs from flowing into our country. So I really appreciate what DEA does, HIDA does, etc. We need to shut down the bad acting doctors and pharmacies. We also want to get these people into treatment, so help where you can with that. And then carry Narcan. You're going to hear from me a little bit later. I'm going to be talking about the Give Life a Chance program. And I hope that you'll choose to be one of those law enforcement agencies that decides to move towards the Give Life a Chance program you'll be hearing about. So thank you so much for listening. I really appreciate the opportunity to share.
April, thank you so much for sharing your story and your perspective. It's very much appreciated. So we were going to take a break, but we are running a little short on time. So we're going to move straight into it. And actually, we're welcoming back April. So our next topic is actually examining some of the best practices that are currently in place. And so our first example of that is the Give Life a Chance program. So April, I'm sorry that you're going back to back here, but welcome back. And we look forward to hearing about this program.
Yeah, thank you. No problem at all. All right, so our Give Life a Chance program, when we've started rolling it out, I actually, as I mentioned earlier, live in San Ramon, and our San Ramon PD was very willing to move into this program, and they are doing it. It's really very simple, and it's basically that, you know, our law enforcement agencies apply for a state grant you're eligible for through the Public Health Department, and you receive free Narcan. The units come to you, and what you would do is distribute them to the officers that are out on patrol. They would basically carry this medication with them every day. And as you encounter someone maybe just after an overdose, or, you know, a situation you encounter that feels as though there could be a high risk, you know, environment or situation going on with an individual or just the environment itself, you leave it behind. You got it for free and you leave it behind for free. So it's as simple as that. The next slide here, if I can move over to it, it's not budging here. Oops, there should be some more other slides. Are you able to help with that, David?
Yeah, I will get that up 1 second, April.
Thank you. Yeah, basically, what I know you'll be provided is the link, and it's going to show up here. You can take a quick snapshot of it. But you just, and in fact, I just did this yesterday myself because nonprofits can apply for it too. We just applied yesterday for our third grant of Narcan, and I asked for 600 units of it. And so what we do is just fill out a little form that gives you a standing order. It results in you getting a standing order from a state doctor that allows you to use the Narcan. You complete the grant application. You have to provide some background information, but it's nothing. I'm sure you have it readily available. And then if you're going to ask for more than 48 units, and a unit is actually one box, so 48 boxes of Narcan, you just have to give them, just on Word document, whatever, a description of what your distribution plan is. So clearly this would be the For You Give Life a Chance program, so super easy. And then just set up a tracking system. We ourselves have set up simply an Excel spreadsheet. It's up on a Google form, Google Drive, and so different members of our organization can input, who they've distributed the Narcan to, and we try to capture in our case, a name and a contact phone number and email address. And you may not be able to always do that, but to at least indicate, you know, what you've distributed in the end, because they do expect that you'll report into them the next time you ask for Narcan, how many saves you believe there have been that have been reported from the Narcan that you've distributed. And so then it's really as simple as that. We really would hope that you would be interested in moving into that. And then David, I think there's another slide here. This is just the page that you'd land on their website. This is an example of what we do, and you could choose to do this or not. We actually put the Narcan in the bag. We include the box because it has directions on how to use it. But then here are the 2 doses of Narcan. We include the mouth breathing guards because of potential for passing on illnesses, etc. But you don't have to do that. Of course, we have the gloves involved are included in our kits as well. But otherwise, you can just simply carry the boxes with you. And then additionally, what we would like to provide our police officers or make sure you know how to get are the 211 cards. In our case, we live in Contra Costa County, but Alameda County has this also. Most counties do the 211 program. And so this directs people to a simple number 211 where they can get services of whatever sort. And that can include any kind of crisis services, whether it's mental health services they require, housing, and of course, recovery services. So this is our contact information. If anyone is interested in learning more or having help in getting this process started, please do contact us. We can also provide flyers that you can post wherever, other materials that we have that are educational in nature that might be of interest. Thank you very much.
Thank you very much, April, for sharing that program. David, would we like to take a break? What do you think?
Yeah, we could take a 1-minute break and then we'll transition into Michelle.
Okay, so if you guys want to come back at 1, we'll do a 1:04. We will see you back in a moment. All right, welcome back, everybody. Sorry for the short breaks, but we are running a little short on time. So thank you so much, April, for sharing that again. Our next example for practices is the Alameda County In Your Corner project. Our speaker is Michelle Schurig. Michelle is the director of In Your Corner, Alameda County Young Adult Opioid Initiative at the Alameda County Probation Department. Michelle grew up in southwestern Virginia and is a second-generation immigrant from Chile. Michelle has a master's in public health from the University of Maryland and is also a Spanish speaker. Michelle has worked for over 20 years in the private and public sector. A common thread throughout her career is applied research and training From supporting a team of consultants to understand the impact of Boys and Girls Clubs in Native American communities, to being an on-site technical advisor for behavioral health teams across the country. Michelle has years of experience training government employees in mental health and substance use, ICD-10 coding, and Title IX-E regarding foster care legislation. She is also co-founder of a free clinic for homeless adults in Santa Cruz. Michelle is passionate about applying her cross-system knowledge to build social and health equity. She loves the outdoors, dancing, and is an avid animal lover. Please welcome Michelle Schurig.
Thank you so much for the introduction. Hi, everybody. I don't see my slides up there. Is there a way to have my slides start?
I requested you to control the screen, Michelle.
Oh, thank you. Okay, I see it now. Okay. It's not working though. It's not moving forward. Okay, here we go. So in your quarter, Alameda County Young Adult Opioid Initiative, first of all, I wanted to say thank you so much for this opportunity to present on this initiative. And thank you so much for my co-presenters and also on those stories of resiliency and hope by Nick and April. I think those are just so critical, especially as we increase awareness about this topic. And also thank you to everybody here from law enforcement for showing up today, and just give yourself a huge pat on the back. This is a long training and there's a lot of great information. So thank you so much. Next slide. I'm not able to control for some reason. This presentation was prepared under a cooperative agreement from the Office of Juvenile Justice and Delinquency Prevention for the United States Department of Justice. And the work is supported by the Alameda County Probation Department. So for our discussion today, we're just going to learn a little bit about the In Your Corner Opioid Initiative and do a little bit of a discussion on how stigma might impact your work, and also to get your input as well. I'd love to hear from everybody there about how language and stigma has shaped your work there. And also, we're going to share some resources and tools that are available through In Your Corner now. What is In Your Corner? So In Your Corner is an education and awareness initiative that's aimed at increasing awareness and ending stigma so that young adults in Oakland can get access to the care they deserve without fear of judgment or loss of benefits. It actually started as the Opioid Affected Youth Initiative, and we rebranded because, you know, one of the things that we want to do is to end stigma around opioid and substance use disorder and recognize it as a chronic health condition that it is. There's a few bubbles that pop up in animation here, David. Okay. So this is you can go back. This is a data-driven approach, meaning that it is grounded in the literature and also research that we've conducted. It's been collaborative, so there's multi-agencies involved, including social services, behavioral health, lots of law enforcement as well. So it's a collaborative project with UC Berkeley, who is evaluating the initiative, and it's supported by research and best practices. In 2019, there was a 500% increase in overdoses in Alameda County. And a lot of this has been driven by fentanyl, and that's just in the young adult age group. As you know, COVID has led to had a huge mental health toll. So we're really alarmed by the uptick that we're seeing in substance use overdoses. And this project in particular, while it can be applicable to everybody, In Your Corner is really focused at trying to increase service utilization for young adults in extended foster care, which is our AB 12 population. As many of you know, these young adults, they've moved many times in their life. There's low trust threshold for good reason. You've been moved around to different group homes and foster homes, then trust is low. So we want to be able to work with our community partners and see how we can impact building trust and having these important conversations around opioid and substance use disorder. Next slide, please. So what we're trying to accomplish, this is really a helpers campaign. So we're focused on building welcoming communities where young people can get support from adults and peers who are ready to help. And this really started with a training series in April. We had 3 different trainings. 2 were focused on leaders and managers of organizations that serve young people in Oakland, and the other was a provider training. We have recording of this training as well. Next slide. So what has stigma got to do with this? Next slide, please. Of the, there's about 21 million plus people who need substance use services in the US, and less than 13% have received any type of treatment. And stigma is a major barrier to seeking help for opioids and substance use. So, I mean, can you imagine if 13% of people with high blood pressure or high cholesterol did not have access to their medications? The number of deaths would just skyrocket. That's what we're dealing with here with the opioid and substance use epidemic. And according to the World Health Organization, substance use addiction is the #1 most stigmatized issue in the world, more than mental health, more than alcohol, other social issues, such as incarceration and homelessness. And often people avoid or delay seeking treatment due to concerns about being treated differently or fears of losing their job and livelihood. As Michaela mentioned earlier, it can take 4 to 7 years between the onset of opioid use disorder and somebody actually getting into treatment. Next slide, please. So I have a couple of very, very short videos, and then we were going to just jump into a quick little discussion in the chat box. Just the first video, please.
There are many, many negative stereotypes out there for people that have an addiction. A junkie, an addict, the person that's seeking meds, hopper, meth head, crackhead. The language is very, very important to a person's self-esteem. Who wants to be known as, oh, the junkie? Who wants to be known as, oh, an addict? Person in recovery, person who's striving for recovery, positive things. When they hear that type of negative talking about the junkie and the addict, that makes people feel less than a person. It makes that person feel hopeless that, maybe that is me. Maybe they're right. That I can't change. This is hopeless. This is endless. Why? So I think that the language should change. Everyone, everywhere should change their language. People in recovery, people that are striving for recovery, that type of language should be used. The positive language to make that individual feel good about themselves, to know that they're doing something that is very, very worthwhile, and it's going to pay off, and it's going to be a benefit to them, as they strive and they climb that mountain of recovery. We lose hope sometimes when we hear that type of language. So if the language would change, our self-esteem would go up, and that plays a very, very remarkable part of your recovery also, your self-esteem. I believe with education, if people can be educated and know exactly what substance use is, exactly what addiction is, exactly what mental illness is, it would be a much better place, for people like me to start.
Thank you. And then the second video is actually from a physician's standpoint, again, talking about language. It's a very short video.
Greetings. My name is Dr. Lippy Roy. I'm a Duke-trained and former Harvard doctor who specializes in addiction medicine. And today I'm going to talk about ways to reduce stigma towards people with addiction by changing our language. So as of right now, in society, we tend to use phrases and words that are pretty tough, punitive, punishing, very stigmatizing. We'll use phrases like substance abuser, drug abuser, or substance abuse, drug abuse. We use the phrase war on drugs. We'll say, we'll label people as junkie, cokehead, addict. And we also, in clinical settings in labs, we'll say things like, oh, your urine is dirty with, your urine is dirty with heroin, alcohol, whatever. And yet, my patients with diabetes, if one of them, say, ate a whole box of cookies in the morning, resulting in a blood sugar of 600, I don't say, oh, you've been abusing chocolate chip cookies, or you've been abusing donuts, and as a result, your urine is dirty with sugar. We just don't use that kind of language. In that case, I abused ice cream last night while watching TV. We just don't use that type of language towards people with other chronic medical diseases like diabetes, heart disease, lupus. Yet we do it with addiction, which is also a chronic medical disease, a disease of the brain. And when patients or people with addiction hear language like that, abuser, dirty urine, they tend to perceive more discrimination and they are less likely to seek help. Studies also show that healthcare professionals like doctors and nurses, physician assistants, nurse practitioners, they actually have less regard for patients with addiction. They perceive people with addiction as being manipulative, angry, violent, less motivated, and they spend less time in clinic. They have shorter visits with people with addiction. All of this adds up to suboptimal care. So instead, I offer an alternative to reducing stigma by changing language. So I invite all of you to start adopting language that's more compassionate and less stigmatizing. Let's use phrases like substance use disorder or a person with substance use issues. Let's say things like your urine is positive for opiates, not dirty, but positive. When studies show that when we use language that's more compassionate and less stigmatizing, patients feel less judged and more respected. They are more likely to seek help. In addition, it also improves the therapeutic relationship between the patient, and the provider, prescriber, or doctor. So overall, when we use language that's more compassionate and less stigmatizing, people are more likely to seek help. So hopefully we can all work together to make these changes, and remember to pass it on, pay it forward. Thank you so much.
Great, next slide, please. So those are just two perspectives, and we're just going to do a quick chat box discussion here. If you could just click into the chat box, what, if anything, stood out for you as part of this video, if anything at all? So changing the name to @promise clients instead of @risk youth speaks to the power of language, that language is important. Thank you so much, Supervisor Gomez of the AB 12 unit. That is very helpful. I think there's a couple other words matter. Thank you. There's a couple other discussion questions in here too. David, if you could, or whoever is moving my presentation, it's animated. Does any of this ring true for what you have witnessed? Thank you, April. How important using appropriate language is to breaking down stigma. Yes, it is very important. And it can really be the break it or make it for somebody who might be wanting to go into treatment. But if they're with somebody who's using terms that are very negative, it really may feel it's already something that's highly stigmatized, and it can really prevent somebody from going to, and the research supports this. It's a major, major barrier to seeking help. There's a final, I think there's one more question on here. And so the other question that we have here is there anything that you could do, this is maybe just something to think about, to help shape language or reduce stigma in your workplace? In the trainings where we had a training for leaders and managers, I think what came up a lot is that there's a lot of policies that include this language, and we're updating policies all the time. So anywhere that we can improve language in writing is going to help reinforce that, and will change how people talk about this disease, which is really important. So thank you for that. I wanted to also just mention that, while language is one example, there's other examples of reducing stigma. For example, self-care is huge. And as in law enforcement, you have a lot of secondary trauma. And so modeling that self-care is huge in terms of helping our clients see how important it is to take a deep breath, to do those things rather than increasing stress, which can be a trigger for many. These are some resources and tools that are available to you now. And we have a web page that includes a toolkit for community providers. And that includes signs and symptoms, how to identify signs and symptoms of opioid and substance use. It includes how to have a conversation about substance use in a way that's non-stigmatizing, that's open, and also where are there local treatment resources. We also have these young adult resource pocket cards that you can see here. It goes by Maslow's hierarchy of needs, meaning it includes information in Oakland where you can get basic food, shelter, and also going up through mental health and substance use. If anybody wants any of these, feel free to email me and I can send these to you. And the other thing that we will be doing are some roadshows and booster trainings at departments in the county. If you're interested in participating in those, or just having us come to your department to do some trainings, we are training young adults in this material as well. So we'll be having some young adults train the materials to others in the community. So it's led by peers in the community as well. And there's some additional resources in the agenda packet. That is all that I have, but again, this is an ongoing initiative and we're continuing to build it. And we would love to have your participation. If you're interested at all in reducing stigma, increasing awareness so that people can get access to care more quickly, just feel free to reach out to me. My email address is right here and there's an additional resource in your agenda packet. Thank you so much for the opportunity.
Thank you, Michelle. We really appreciate it. So we have one more example for you for best practices. Our third example is the Contra Costa County Choosing Change program. Dr. Lisa Verdella is a staff physician at Contra Costa Regional Medical Center in Martinez, California. She is board certified in both family medicine and addiction medicine. She currently serves as the lead physician for Choosing Change, a medication-assisted treatment program for opioid use disorder. Her clinical focus is on providing care for pregnant women who struggle with substance use disorders. She is originally from San Francisco and currently resides in Martinez with her husband, son, and 4 dogs. Please welcome Dr. Verdello.
Hi, everybody. Thank you so much. And I'm going to echo grateful that we're having this chance to get together and share knowledge, and especially grateful for all you do for our patients and our community. So Choosing Change is the name of the program that we, through Contra Costa Health Services, facilitate for the treatment of opiate use disorder for our county patients, Medi-Cal patients. Next slide. This is just a snapshot of our website. I'll give you more contact info towards the end and how to get people enrolled that are interested in, but you can see right off the top, there's our phone number down at the bottom, where it says interested in choosing change. This is actually a quilt made by our patients talking about what recovery meant to them. And so this was done a few years ago, and I just wanted to show that really quickly because it's something I think we're all really proud of here in our program. Next slide. Okay, so what does opiate use disorder? Really quickly, going to go over this because you guys have been talking about this all day. We know it's a medical condition, not a character flaw. We know that the brain is physically and chemically remodeled after repeated exposure to a substance. Really, regardless of what that substance is, it could be heroin, caffeine, alcohol, even a non-substance like gambling, anything that lights up those dopamine stores. We know that as a result of this brain remodeling, it alters our decision-making pathways. So the maladaptive behavior that we see and that you as law enforcement are exposed to all the time is a symptom of the disease. So we in the healthcare side are aiming to treat that disease so that you don't have to see so much of the symptoms in our communities. We know it's treatable, and treatment is life-saving. In a huge contrast to methamphetamine and stimulants and other diseases that are really difficult to treat, opiate use disorder is absolutely treatable and treatment is life-saving. So we should make it readily available to our community. Next slide. Basics of opiate use disorder treatment. I'm going to use this acronym OUD for opiate use disorder. Medication assistance. So what do we offer through Choosing Change? We offer these 5 things primarily. So medication assistance is one of them. Primarily buprenorphine. It goes by the brand name Suboxone or Subutex. Also, there are a few other brand names out there, but you guys might have, they're referred to on the streets often as subs. Methadone is included in that. However, we do not prescribe methadone through Choosing Change because of a federal law. You have to go to get it dispensed at the BART clinics daily and sometimes even weekly once you prove stability. But the nice thing about buprenorphine is that we're able to prescribe it so patients can pick up a month's supply at the pharmacy. We also facilitate recovery-oriented activities and mental health treatment, medical care when appropriate, and we address social services through housing and transportation in collaboration with other services offered through the county. So it's not that we directly provide all these things, but we are often the link between our patients who come for buprenorphine treatment and then they seek out mental health, they seek out medical care, they seek out social services and start to kind of get their life together. I also want to acknowledge Phoebe Oliveira, who is on our call today. She is like the mother of the entire program and has got it through the COVID epidemic, which is saying a lot specifically because of the amount of overdoses and the increased rate of referrals that we've been seeing recently. So I just want to give a shout out to Phoebe. Next slide. Okay, so basic tenet of what we do, harm reduction. You guys have been talking about this, so I'm not going to focus too much, but basically we try to start where the patient is at. We listen to their journey as you have done today. What is their story? We know that one size fits all treatment doesn't work, so we try to individualize it as much as possible while using the group model for treatment. We also acknowledge and recognize that relapse is common, not universal, but it's very common. What happens when a patient relapses? Well, we just pick up where we left off, and we don't, the last thing we want to do is shame them. We want to keep that door open so they come back. That leads to my next thing, open door policy. So patients can get referred in by themselves. They can call and get treatment. They can be referred by their primary care provider also. So multiple routes to getting in. It's hard to get kicked out of our program. And what do I mean by that? I mean, if if a patient relapses continually, if a patient is struggling with resources or trying to get comply with our program requirements, we're not going to kick them out. Obviously, we'll talk to them about our concerns, but we also we will hardly ever shut the door on a patient. The only reason we would do that is if a patient became threatening or was doing other kinds of harm to our program patients or staff. Next slide. Naloxone, you guys also went over this today earlier. Or intramuscular, there's intranasal. Important thing is you don't need a prescription. It's available at any pharmacy. However, we are prescribing it, we're supposed to prescribe it with each opiate that we prescribe. I also tell patients always call 911 after you give naloxone, because even if that person wakes up right away, it will wear off after 15 to 20 minutes, especially with all the fentanyl that we're seeing. And I always tell them there's no harm in trying. If you're not sure if the overdose is really opiate related, or maybe it's alcohol, or maybe it's diabetic, who knows? You don't know. It's okay to administer Narcan. You're not going to do harm. Next slide. This is just a quick, because this is one thing that I've run into, especially with my patients who are mothers or new mothers, and they encounter people asking them, well, aren't you just trading your heroin addiction for another addiction, meaning buprenorphine treatment? So is buprenorphine treatment just trading one addiction for another? No. With successful buprenorphine treatment, the compulsive behavior, the loss of control, the constant cravings, and all the other hallmarks of addiction vanish. When all signs and symptoms of the disease of the addiction vanish, we call that remission, not switching addictions. So again, it's about the way we approach and the way we categorize treatment versus addiction. Next slide. So how to enroll. This is the phone number to call if patients are interested in. They'll get an intake, and or they could tell their doctor that they want to be referred in, or doctors can refer in from the ER or from mental health, lots of different places. We often get patients who are saying, my friend told me about you guys and I need to get help too. So next slide. Questions. There's my cell phone and my email. I'm happy to answer at any time. And then you can obviously reach any of us, including Phoebe, through the information on the website. Thank you so much for listening.
Thank you, Dr. Rodella. We really appreciate it. Okay, I'll pass it over to David.
With that, thank you all so much for attending our law enforcement's role in tackling the opioid epidemic event. We appreciate all of your participation and would like to thank all of our presenters one more time. We will be sending out a post-event survey to all attendees, and once completed, you will receive a certificate of completion. Thank you all and have a great rest of your week.
Bye.